want to introduce our panel. We have Dr. Kumar Bellani, who is a distinguished international professor at the Academic Health Center, University of Minnesota, and serves as a professor in the Department of Anesthesiology and as an adjunct professor in medicine, pediatrics, and environmental health sciences in the schools of medicine and public health at the University of Minnesota. He serves as an anesthesiologist in chief at the University of Minnesota Masonic Children's Hospital and has led the collaborative activities between India and the University of Minnesota.
So good morning to everybody, and I want to thank the organizers of CAHOTECH for having me be part of this panel, particularly to Nagendra, to Samir, and also to Sam for arranging this. I bring you greetings from Minnesota. I don't know if all of you know, it's the land of many, many lakes, 10,000 lakes and more, if you haven't been to Minnesota. So my name is Kumar Bellani, as I was introduced. I'm at the University of Minnesota. I belong to the Academic Health Center with appointments in anesthesiology, medicine, pediatrics, and public health, which are my areas of interest. Now, we all have been affected by this pandemic, as everybody knows, as much as any other academic institution. And here you can see a statement that was made recently by our president, Joan Gable, and she essentially says that the pandemic has created challenging circumstances, not only here, but several and practically every educational institution. And it appears that until there is an effective vaccine, the best path to success depends upon both personal decisions as well as institutional decisions to protect not only the community, but ourselves. Now, our Academic Health Center is one of the largest conglomerations of health-related schools. As you can see listed on the slide, we have schools of dentistry, medical school, school of nursing, college of pharmacy, school of public health, vet medicine, and also centers for allied health programs and other centers and institutions like the Center for Global Health and Social Responsibility, which has allowed me to collaborate with India. So it's one of the largest academic institutions, not only in the United States, but probably with many other, many other places in different countries. Now we have over 44,000 undergraduate students, as you can see here, and over 17,000 graduates and professionals, as well as 26,000 employees. Now, where I belong is mainly to the medical school. And as you can see here, we have over 900 medical students, and we have 56 MD, PhD students, and over 1,000 residents and fellows. And you can see here listed here, our goal is to educate people so that we can change the practice of medicine. And this is exactly what we are doing today, is we are trying to bring about a paradigm shift so that people can learn in this changing environment. Now, what exactly has happened during this paradigm shift? I'll give you the practical aspects. We heard a lot from John, which was good as an introduction. During the early phase of this pandemic, we had a campus lockdown. So only essential individuals were allowed on campus. And in the hospitals, elective surgeries were essentially stopped, and only urgent and emergent surgeries and admissions for medical care took place. The one essential thing that we promoted was COVID-related research, which was prioritized and allowed to continue. And I must say that we have over 75 research projects, including several related to the actual treatment of patients with COVID. We also were able to, from our department, come up with the Centers for Medical Design, a respirator, which was made available free online to people to copy the design and make them so that these respirators could be easily made for less than $100. And this was popularized throughout the world. And we were able to make that available. And you can see a picture on the right where we have actually made this patient isolation unit where the breathing exhale gases can be effectively removed by this special HEPA filter so that non-invasive respiratory therapies can be administered to patients that actually have COVID. And as discussed to a certain extent already, we had to quickly come together to see how we can promote education to our students. And we had to increase our digital learning programs, their planning. We had to have committees to come together to help and promote these activities. And faculty planning meetings were done remotely. We had to restructure our coursework so that the students who are actually paying fees could get the benefit of all the programs. The unfortunate thing is that because of this pandemic, international rotations, we have approximately 2,400 or more students that study abroad. We have over 7,000 international students, and we have 130 nations on campus. So we are a globally connected university, and we had to stop the international elective rotators on site, and they had to be returned to their home countries. And future visiting rotators for electives are currently on hold. And we hope that we can somehow get their education done remotely if possible. We have our own fellows and residents, as well as surgeons who do go abroad to do surgical procedures and teach people. And those also are currently on hold and have to figure out how to do this correctly. Now, to make this situation effective on a practical level on ground, we put several pandemic protocols in place. We created a command center, and this was to not only plan these protocols, but also enforce these protocols. And this command center was available 24/7 for questions that came up from time to time. And the command center published a daily bulletin with updates so that COVID has been a changing thing every day with new things coming up, and how do we update this. And this was through daily bulletins that were distributed to the directors of different subdivisions. And for instance, in the operating rooms, the directors would get a daily update on what should be done to patients that present. And this was effective for all colleges, including the medical school. We did have a revised visitor policy, and we began enforcing hygienic and respiratory isolation procedures, both for workers as well as for patients, as you can believe. And you can see on the right the figure, we all had to wear face masks, face shields, and the hygienic principles of hand washing. And before you enter the medical building, you had to sign, you have to click off that you were not suffering from any fever or any symptoms that could suggest that somebody had COVID. Now, for medical students, we established a robust digital platform. The course coordinator had to conduct, when we get these medical students coming from one class to another, we had to have them introduced properly. And this was done digitally by having the course reviewed in a digital platform. A mentor was assigned for each student for the course so that the mentor could be available to answer any questions, make sure that they were actually aware of what things to do. And there was a contactless pickup of reading material from a keyless entry door that we made available. And the review of the course material was done digitally between mentor and mentee. Now, we realized that you couldn't just have the students learn digitally without actually having real contact with patients. During the lockdown, we did not have any live patient interactions. And fortunate for us, we had already planned an advanced use of a health sciences education center, and the building was just completed in February. And we used this advanced Health Sciences Education Center, where we demonstrated safe techniques, procedures, protocols with the use of computer simulation programs and high fidelity mannequins, something that John already showed about how people can get individually trained using technologies. And these technologies are now in place in this Health Sciences Education Center. It's a large building. We have real operating rooms. We have real places where people can learn different things. And we also have a place where there can be communication between each other for teamwork, because teamwork is essential. And we do follow procedures of strict hygiene and protocols so that anybody coming into that building is properly protected and wears masks and things that will lessen the transmission of virus. It's not only this virus, there are going to be multiple such respiratory isolations needed in the future. So I think this will go on for quite some time in the future. So elective surgery now has resumed because of the availability of testing for COVID-19. This has really changed the way we practice. We're using a tiered protocol where patients are now allowed to come back. Every patient is tested for COVID before they get into any surgical procedure, or if they come into the hospital and they're admitted. And but what's stayed is that the didactic programs have remained entirely digital. We are actually finding that using these digital programs, the attendance is better, and there is good interaction between trainer and trainee and the instructor and the instructee. So, and there's a good relationship between the chat sessions that are going on between the instructor and the students that are attending the class. Our visiting professor program has allowed us to bring professors not only from the United States digitally, but all over the world. So I think this digital program will be of benefit, and we can actually utilize this system where we can actually bring experts from anywhere in the world and be part of the training program for not only students, but also graduates and for continuing educational systems throughout the world. We do follow campus-wide protocols for hygiene, and especially during patient interactions, we all have to make sure that we wear the face coverings and we have our gloves on and things like that. So this has been quite a paradigm shift. So in summary, what we've done is we've increased the use of the digital platform for didactics. We do have local, national, and international talks done digitally. The key thing is, like Samir said, we need a robust internet system, and it relies on this robustness to make this thing work properly. There's a significant increased use of the Health Sciences Education Center. We have high fidelity simulation. We promote teamwork there, and also the learning of newer technologies. We follow hygienic principles and protocols system wide. This morning, for instance, because I'm at this program, we are actually having a virtual open house for our Department of Anesthesiology, because all medical students are now applying for their graduate training, and they will soon be interviewing for the residencies. And we already have 100 people that have signed up for this virtual, open house. And we had to spend almost a month to make sure that things that we would be able to show this digitally was done properly. And the virtual open house is actually going on right now as I'm talking to you with this meeting. So our goal is that we want to make life as same as it was before the pandemic, and our students will be encouraged to do these activities as listed on the slide. The unions, the events, the student-sponsored programs, art, education, games and competitions, etc. But it has to be done in a way where this infection cannot spread. So we have protocols in place as to how many people can get together, what should be the distancing, promote outdoor programs rather than inside building events, and minimize the number of people within the buildings. But we are doing hybrid programs for education. The instructors all have planned out their training classes so that people can take them either digitally all or in a hybrid fashion, and some of it where they can do it live in a controlled fashion. So the one of the things we did was because COVID pandemic has created problems with depression and mental issues. We have established a buddy program for mental wellness, and this is published in Anesthesia Analgesia just a month and a half ago, and this was rapidly allowed to be published so that people can do this within their systems to promote mental wellness. So I will stop here and then be available to answer any questions. Thank you.
Great, Dr. Bellani. Thank you very much. Dr. Bellani, a quick question from the audience. With all the R&D projects that you guys are doing at the University of Minnesota, what do you see as the top one or two low-hanging fruits that hospitals in India should do from that R&D that's quick to implement, that'll have a lasting positive impact?
Can you hear me? Is it okay?
Yeah.
Good. So I think one thing came out pretty loud and clear is to have a health education program for the hospital employees as well as for the students, which can be done in a systematic way, digitally as much as possible, and the same program that was shown by John earlier. So those things can be implemented so that all the employees can be properly updated and the CME given right, in a regular fashion. The second thing is employee satisfaction was crucial because we had to shut down a lot of things. And then many of the employees were on furlough. And that creates a mental problems on many people. And so we need to have hospitals create a reserve fund for these types of catastrophes so that employees feel confident that this will not happen in the future for them. And that's what we are doing right now in our health system, is to create this reserve fund. The third thing is wellness of the employees is crucial, and this buddy system so that people can confidentially as well as openly talk to their buddy so that these issues can be brought up without any punishment on the part that they brought this issue up, so that they can talk freely, and this can be brought up to the command center, and the command center can then fix it. Because the hardest thing we are facing right now is finding employees to come back to work, because the workload has quadrupled once we've lifted the issues that are going on. So these are good hanging fruits. The other thing is having a very robust microbiology laboratory, because they are overworked right now. Testing takes time. We have to employ robotics to get the testing done, and everybody wants the result as quickly as possible. And I think that's where we have a shortage. So for the next, at least for the next 2 years, if these things can be implemented, hospitals will do well.
Great, great. Thank you, Dr. Bellani.